Good morning, everyone. It is so great to see everyone. I'm so excited that everyone's up at 9 a.m. to be at our meeting. This is the first meeting of the Client Family and Community Inclusion Lived Experience Diversity Advisory Committee. That's a lot of words, but also known as the CFC Committee. My name is Rachel Chambers, and I have the honor of serving as the chair of the committee. And I'm joined and honored to be joined by Myra Alvarez, who is serving as the vice chair of the committee. Vice Chair, would you like to introduce yourself?
I'm happy to. Thank you, Chair Chambers. Good morning, everyone. Buenos dias. It's great to have you here with us. We are eager for this conversation and looking forward to your participation and continued partnership moving forward. Right back to you, Chair.
Thank you. And since this is our first time that we're all meeting together in this capacity, I would like to take some time for some introductions so we can just really get to know each other. Introductions of the committee members specifically. Let's begin in alphabetical order. I am not really good at names, so you have to please correct me. I will not be offended committee member Admasu. Please go ahead and introduce yourself if you're here.
Oh, before we start, I don't hate to interrupt, Commissioner Chambers. Can we do roll call first to establish quorum, and then we'll hop into introductions? Does that work?
Sure. Am I going off the wrong agenda? So I'm fine with whatever you say.
Okay, I'll just call roll, and then we can just pick up where we left off. Is that
all right? Got you.
okay?
So
Sounds
let me
good.
navigate to that section. Then okay, so Sandra, then right? Wait, no,
Yes.
wait, no, I need to
Yes.
read the Bagley Keene thing, right?
Correct. That we're
Okay.
asking all committee members to have their cameras on and all that jazz.
Okay, I'll start there. Thank you so much for your guidance. Thank you, everyone. And now we'll take a roll and establish quorum. Please note that under the Bagley King Open Meetings Act, committee members participating remotely must keep their camera on at all times and will be asked during the roll call to disclose if they have any adults over the age of 18 in the room with them during the meeting and the nature of these, the relationship and the nature of their relationship with these individuals. Sandra, can you please take roll?
Great. And I'm asking all committee members to turn their cameras on and unmute themselves right now to make it a lot easier for me to have the process go smoother, and also to be ready to identify whether anybody over the age of 18 is in the room with you. Commissioner Member Admasu.
Present.
Thank you. Commissioner Member Ayala.
Present.
Commissioner Member Chavez. Oh, and please tell me whether you have somebody in the room with you. I'm sorry. So we'll go back to Commissioner Member Admasu.
Present. I'm from CLCC. It used to be, yes.
And is anybody in the room over the age of 18 in the room with you?
No, it's just me. Sorry, there's a lot of noise. I'm in a conference, so I'm trying to use both my phone and
That's okay. Thank you so much. Commissioner Member Ayala, is anybody in the room with you over the age of 18?
No.
Thank you. Commissioner Member Chavez. Commissioner Member Chavez? Marking absent. Commissioner Member Dura.
Yes, I'm present and no to your question.
Thank you. Commissioner Member Gansweg. Commissioner Member Gansweg? Marking absent. Commissioner Member Gilmer. Committee Member Gilmer, marking absent. Committee Member Kayali. Member Kayali, marking absent. Committee Member Keshazanovsky. Committee Member Kishanovsky, marking absent. Committee Member McFetter. McFetter, calling absent. Committee Member Novotny.
Present. No one's in the room with me.
Thank you. Committee Member Owen.
Present, no.
Thank you. Committee Member Robison.
Present, and I'm alone.
Thank you. Committee member Zhang. Committee member Zhang, marking absent. Committee member Zaldivar.
Present, and I'm alone.
Thank you. Committee vice chair Alvarez.
Here. And I'm alone.
Thank you. Committee chair Chambers.
Present.
And you're alone?
No, I'm alone. Thank you.
Thank you. We have quorum. Thank you.
Thank you. And now I'll go back, if that's okay, Sandra, to just introductions.
Perfectly. Go back. You can go right.
Thank you. Since we've already kind of taken roll, I mean, I can just, we want to start with committee member Admasu? I'm saying it wrong tonight.
I'm fine. You're good, Risha.
Thank you.
Thank you, guys. My name is Untitled Chapter. I'm from African Communities Public Health Coalition. It's a nonprofit organization located in LA. So I'm honored to serve in this subcommittee again. I've been serving this committee the last 4 years at CLCC. Thank you.
Thank you for being here. I appreciate you. And we'll go, it just isn't just in alphabetical order. So then we'll go next with committee member Ayala.
Hi, Grand Rising, everybody. Good morning. Buenos dias. My name is Carolina Ayala. I'm the founder and executive director with the Happier Life Project. We are a recovery community organization located in the Inland Empire, and I am grateful to be here. Thank you so much.
Thank you. I don't think committee member Chavez was here. If I'm incorrect.
Yes, I'm here. I just logged on. I'm sorry.
Oh, okay. So Sandra, do we want to mark the roll or?
Yes, I will update roll. Committee member Chavez, is anybody in the room over the age of 18 with you?
No, nobody's in the room with me.
Thank you.
Well, thank you for coming, committee member Chavez. We're just doing some like 10-second, 20-second introductions. And since we haven't met all together as one, we just want to introduce yourself.
Yeah, sure. My name is Veronica Chavez. I'm a psychologist with Children's Hospital Los Angeles, and I work in the area of childhood trauma, in particular with kids in foster care and adoptions. We get referrals from all over the county of Los Angeles with kids who have been experienced or exposed to any type of trauma-related histories and symptoms.
That's amazing. And thank you for being here. I really love that we're all showing up and the expertise in the room. I don't know, committee member Dura.
Yes. Hi, everyone. My name is Eugene Dura. I am a mental health services manager with Solano County Behavioral Health. My roles here, I'm our BHSA coordinator, ethnic services manager. I also oversee our wellness and recovery peer efforts, suicide prevention, and then community engagement.
Thank you for being here. Appreciate you. I don't know if committee member Kazazakowski is here. Richard, not the other Richard. No, I don't think he's here. We'll wait for him next round. We'll put him at the end if he comes back. Committee member Owen.
Hi, my name is Larissa Owen, and my firm is IntelliQuest Consulting. We're a service-disabled, veteran-owned small business, micro business.
Nice to have you here. Thank you. We'll go to committee Robeson. I always say it wrong, Jason. I'm sorry.
It's no worries. It's all right. Jason Robinson. I'm a person in long-term recovery, and that means substance use and mental health issues. I'm also a family member, and I am the chief program officer for a peer-run organization in Los Angeles that has approximately 80 staff that are all trained peer specialists and work in housing, peer respites, community centers, and our organization is a statewide trainer for the peer certification and all the specialists under the peer certification training. So family, justice involved, working with unhoused individuals in crisis response. And I'm also on the board of directors of the California Association of Mental Health Peer-Run Organizations. Great to be with you, and thank you.
It's great to have you here, Jason. And committee member Zalazar, I always know you as Richard, but sorry, correct me.
Rachel, it's fine. It's morning. It's Saldivar. I used to be called other things in high school, but you're doing fine.
All
Good
right.
morning. My name is Richard Saldivar, and I'm the executive director and the founder of the Wallace Memorials here in Los Angeles, where we build an AIDS monument to people who died of AIDS. We provide HIV, substance use, and mental health prevention in Los Angeles County. And again, it's great to be back on this committee, and I'm looking forward to a great year. Thank you.
Thank you. It was great to have everyone here. I'm just going to check to make sure that we're at agenda item 2 now. Announcements. Yes, I can't really see.
Yes,
Okay.
please
I'm
go
gonna
ahead.
go with that. Thank
Commissioner
you.
Chambers, actually, we also had committee members Gilmer and committee member Novotny join the meeting. So they weren't listed on the working agenda, but they are also available for intros.
Okay, can you announce them one by one since I'm not?
Yes.
Okay.
Committee member Gilmer, if you want to go ahead. Oh, it looks like he actually might not be. He might have left. We'll go ahead with committee member Novotny.
Hi, I'm a family member from Mendocino County with lived experience. I was the founding member and former executive director of a peer-run nonprofit, currently on the board and board chair of NAMI Mendocino, which we're focused on in-reach into our native tribes with a native grandmother who is providing education and support.
Great to have you here.
Thank you.
Appreciate you. Did we get the other committee member back, Mariani?
No, they haven't joined just yet, but if they do, I can let you know.
And do they need to be asked about on the roll, Sandra, or did you already capture them?
I already captured committee member Novotny, and Gilmore I did not, but is Gilmore back on?
No, they are not back on.
Okay, so we're good.
Okay. Now we're moving to agenda item number 2, announcements. Before we begin, as a reminder, we will be abiding by Bagley-Keene laws for these meetings. However, as a part of our commitment to a deeper public involvement and open governance, all advisory committee meetings feature an enhanced public comments section. So it's a little bit more enhanced, designed to promote genuine dialogue between the committee and the community. And that's real. So even though we're abiding by this, know that this is where we can have, I will hope to have like deeper conversations about solution focused ways that we can really influence the other committees in the full commission. Now we're going into announcements. In case you missed it, the commission's budget and fiscal advisory committee, the program advisory committee, and the legislative external affairs committee met last week on September 18th. And you all can access those recordings, recordings of the meetings on our website. As for this committee, the commission has approved the temporary merger, as you all might have known, of the Client and Family Leadership Committee, CFLC, and the Cultural and Linguistic Competence Committee, CLCC, into this new advisory body, the CFC Committee, as stated earlier. This temporary merger will enable us to collaborate on the development of the Innovations Partnership Fund, which I'm sure has been on everybody's mind like mine's, which is operating under a very tight timeline. So we're going to be strong together. In addition to that work, this committee will also address other relevant issues, some of which might align with priorities of the 3 other committees. We met 3 times on the 4th Thursday of the, we will meet 3 times on the 4th Thursday of the month when there is no full commission meeting. So we'll meet when there's no commission meeting on those months. And after those 3 committee meetings, the full commission will reconsider the path. So I think that this is an opportunity for us to really dig deep into our power, and then, you know, I think that we'll be able to inform the commission on our merger. I look forward to ensuring that the commission's work remains grounded in equity, cultural responsiveness, and uplifting client and family voices. And I mean, anyone that knows both me and Myra's vice chair and chair, we are really grounded and are committed to ensuring equity, cultural responsiveness, and uplifting clients and family voices. So you're going to get nothing but that commitment from us. The next announcement, the Commission's Peer Respite Project, exploring operations, impacts, challenges, and best practice of peer respites, and providing alternatives to hospitalization, and I believe also incarceration for those experiencing behavioral health crisis. So we are doing a lot of work. And we actually just met in Santa Cruz 2 days ago, and 2 other commissioners went with us, and we are just exploring all the peer respites across the state, including Share that's on here. And then the Mental Health Wellness Act has carved out $20 million specifically for promoting peer respites across the state. The commission staff, along with myself, are talking to experts, like I just noted, operators of peer respites, including some of the individuals I just mentioned, county behavioral health staff and directors involved in peer services, and people with lived experience to inform our strategy for awarding these funds. So like I said, like the commission staff is doing like wild, amazing work on really trying to organize like what are the best practices across the state, and like how we can look at evaluation tools and fidelity to the model in alignment. And this is kind of off script, but in alignment with the governor's behavioral health transformation. So I think the commission staff, I just want to honor the work that they're doing. The team is putting together a proposal that will be shared with the Program Advisory Committee in December, with the full commission in January 2026, with a tentative release of the RFA following after. So that's really exciting, and I really hope that that this committee also could play a role and to inform and that too, because everything that's grounded in our mission with like equity, culturally responsiveness, focusing on families, clients, and peers is grounded in the peer respite and ensuring that people have a full access to the continuum of care through these services. So I'm excited about that work. And the last item, I like to kind of go off script. Finally, our next commission meeting is October 3rd, 23rd, not 3rd, 23rd for the record, in Sacramento. For more information on any of these items, please visit our website and sign up for our email list distribution. And I don't know what our resources are or what other people's agency resources are, but I mean, I think that if you're interested like in understanding more of like what the commission staff is doing and the researchers, I think it's really, I think I would be open to talking more because it's just really exciting. And that concludes our announcements for this morning. I talked a lot. I think I'm gonna be talking a lot more. Now it's time for our general public comment, so I don't have to talk as much now. This is agenda item number 3, general public comment. This time is reserved for comments that are not on the agenda. So the things that are not on the agenda. And then now I'll get to give Amariani a chance to lead us into public comment.
Thank you, Chair. If you'd like a live meeting transcription or closed captioning, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. If there are any members of the public using translation technology, please notify the chair so that we can be mindful of that. You may request to make public comment by submitting a card, clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. Members of the public can also email us public comment to be shared at a future meeting at publiccomment@bhsoac.ca.gov. I will now go over public comment procedures. For members of public in the room, if you have not already, please use one of the green public comment cards located at the front to indicate you would like to make comment on this item and any other agenda items. Cards can be given to staff located at the front table. When it is your turn to comment, I will call you to the podium or unmute your line and announce your name or the last 3 digits of your telephone number. We truly appreciate your understanding with this process. We will now hear in-room comments. We have one comment from Karen.
Thank you. Like I say, it's really weird talking to an empty room here. Karen Vicari with Mental Health America of California. Thank you for allowing me to make public comment this morning. First, I would like to say that we truly appreciate the increased transparency of the Commission under its new leadership. My comment today relates to the new committee process, and it's actually more questions than comments. We understand that certain items will now go to 2 committees and must be approved by both committees before they're sent to the full commission for discussion. And we get that. That makes sense because if a committee were to request edits, it would delay the whole process. Recently, the Innovation Partnership Fund last week was discussed at the program's advisory committee, and there was a lot of community feedback. But the item was approved as is, and there really wasn't discussion by the committee of the public feedback. That same item, of course, will be discussed today, and I assume it will also be approved as is. My questions are, 1, what happens to the community feedback at committee meetings? 2, is that feedback presented to the full commission prior to the commission meeting to aid in their discussion? 3, is it possible for committees like this committee to actually have a discussion and send a list of recommended edits to the full commission based on feedback? And 4, how can we know that the feedback, community feedback, is incorporated into the final product? That's all I have. Thank you for letting me comment.
Thank you, Karen. That was our last in-room comment. Online, we have a comment from Stacy. Your line is open.
Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition, and for Safe Passages. First, I want to let you know that I think I saw Jim Gilmer's name in the members, and I would have put it in the chat, but you've disabled the chat. So I was hoping that the chat could be not disabled because, again, this is a committee meeting, and in some of the other committee meetings, they've had it open so we can speak to each other or put notices in the chat. I really want to thank Karen Vicari for all her comments, including, again, thanking the commission for their new transparency and efforts at including community voices. It's just so refreshing, and we really want to support and help you. However, I do want to, related to some of the things that Karen said, I want to congratulate the committee members because you've been chosen, we were told, because you agreed to be in some form to move forward on this committee. But I really would suggest that you look, again, in transparency, you should view the tape of the commission meeting on August 28th regarding the issue of putting these committees together, because there were many comments about the merging of these committees. And since the decision is not yet final whether or not we will go back to having a separate CFLC and CLCC, I think you should go look and see what the concerns are of the public since you're on this new committee. Other than that, I also want to really thank Commissioner Tsai for coming, because I think it really shows interest and commitment to the issues that both of these committees, you know, are devoted to, and I really want to thank him. Thank you.
Thank you, Stacy. That was our last public comment.
I want to just say thank you for everyone's comments. I don't know if I can just respond back to some of the statements.
Yes, we've relaxed the Robert's rule, so you please feel free to respond.
I want to just like commend everybody that showed up at the meeting and voiced their concerns and their excitement about this opportunity. I believe that just as you all as the public, you know, made statements that were very valid, I believe that us as commissioners as well have shared the same sentiment. And I believe that we, with the resources, and I mean, the chair can definitely step in with the resources that we had. And we believe that the power that we had together, we believe that in the time crunch that we had to get our voices heard, was the way that we could utilize the resources and get the power, get it documented, our voices be heard. I mean, I just want to say that I wholeheartedly agree. I don't, there's nothing that I could say outside of I agree. And I believe that I, as a public officer, trying to align with the governor's agenda and the client and family and their cultural and linguistic committee, did what was best for us to be able to get our voices heard throughout the committees. And I believe still that I'm excited about the power that I see in this room and the impact that we have. And so I just want to let you know. And then related to the public comments I am a part of the program committee meeting. And I do want to say, and thank you, Stacy, for shouting out Dr. Sai. I want to thank Dr. Sai for being here and your commitment to hearing our voices too. It's always a pleasure to have another commissioner and also advocate in the field here, listening to the voices of our diverse communities and our client and family. So just want to say thank you. I do want to commission the commission staff to, you know, Chair, I got you in 1 second, to be able to support us on like how we can utilize that public comment to be able to inform from the other committee, from the public program committee. I mean, I definitely serve and can be able to bring, you know, any insights. And I know that there's some people on here, but I do think that that is a consideration, and I do want to uplift that. But I know if Vice Chair wants to add anything, but I wanted to say thank you for your comments.
Thank you, Chair Chambers. I just want to echo your comments with deep appreciation for the feedback that was received at the last commission meeting, and also for the time and attention that folks are bringing to this committee meeting. And in particular, want to respond and agree with some of the questions that Karen raised. And not agree with the question, but give some thoughts and reflections. In particular, this concept of a feedback loop is particularly important. The idea of having a meaningful community engagement process as part of the commission's work and responsibility is to circle back with the committee to say, here is where we were able to incorporate that feedback, here's where we were not, and give some sort of context around that decision making. And so for the staff, a standing committee agenda item could be next steps from the previous meeting, right? So that it's already built into our structure. It's not something that we have to think about, but that we are circling back on the discussion from the previous meeting. And so I want to acknowledge that one of the reasons why we are doing this combined committee is to have tangible ways in which we can incorporate this feedback so that our committees are not performative, that we're not just checking boxes, but that we are actually creating processes that allow for us to incorporate this feedback in the commission's practices of the work products moving forward. And like we said at the commission meeting, it's a work in progress. right? We've not done this before. We are trying something new. And so your feedback and your thoughts and reflections, particularly our committee members, but members of the public as well, we welcome that in order to improve our efforts moving forward. So thanks so much for that partnership, but also for that trust and confidence that we're doing this together.
Sandra, I see committee member Robinson's hand. I don't know if it's, can we?
You can call as the last public comment and then move on, because we do have a long agenda, but you definitely, if he has a general, is it a general public comment?
Committee member, would
No,
you like to?
I'm a committee member, and I have a question about the process for some of the public comments that were raised.
Well, their legal is here, so you want to, Chandra?
Yes, please.
Okay, great, thank you. I really appreciate the public input, and I'm wondering, as a committee, we got a packet of materials for the meeting, and in instances where public comment has been submitted about something that's on our agenda and it's in our packet, I'm wondering, I don't know what the timeline is, but it would be great to see if there's a way to get a transcript of the previous public comment into those meeting materials.
I'm not understanding it. There was a public comment included in your materials?
No, what I'm saying is, Karen Vicari mentioned that there was already public comment about the Innovation Program Fund. That item is on our agenda. So for us to consider that agenda item, it would be really helpful to have a transcript or a synthesis of the public comment that was previously provided, so we don't have to go backward or we don't miss anything that, the public has included in the process.
And I just want to know, and I think I'm looking to our staff, are they discussing about public comment for another committee, like at the program advisory committee, or was it
commission, Sandra?
From the last commission meeting?
Yes.
Okay.
Right. And so as you all do those minutes, and I don't know if committee member Robison's comments, we don't know if the timing works out, but if there's a transcript from the commission meeting with that public comment, it's relevant for the committee members to understand that. Just
got it. Yes. And it's
every time, but if it is relevant, I think what he's asking for is to be included as part of the background materials for the committee discussion.
Oh, absolutely. And the only problem here is timing, because the video for that public meeting is on our website, but there's a delay and a lag from our transcriptionist getting that to us. So that has not been, and we usually have to wait for the commission to approve the transcript to make it public. So but the video with all those public comments is on our website that includes it. And as soon as we can get, the packet out for the following commission meeting, but I'm afraid that the timing doesn't work this time around because of the quickness. But again, if you are willing to see the video is on our website.
Okay, well, maybe we just add a link in our packages if we have time, at least a link to the video.
I can drop it into the chat. So there'll be a link to the video, and you can actually click to the IPF item on the website and it'll take you to that.
All right, well, thank you so much. And now we'll move on, and I appreciate all the comments. And now we're getting into I think the really fruitful conversation. Agenda item number 4 is a report on the Innovation Partners Fund. This item will review the status of the IPF, as well as provide an overview of the 3 listening sessions that were held over the last 4 months. At this time, I'd like to invite CBH Commissioner Gary Tsai, as well as the Deputy Director of Research Evaluation Programs, Melissa Martin Mollard, to provide an update. Please welcome those individuals, and please go ahead.
Thank you, Chair Chambers. Good morning, everyone. Appreciate the shout outs. I appreciate being here. I'm Gary Tsai. I I am a commissioner on the Commission for Behavioral Health. I'm chair of the Program Advisory Committee, which obviously is involved in the Innovation Partnership Fund, or IPF, process. So happy to talk about that a bit. I'm going to start off with just a very quick opening, and then I'm going to hand it off to Melissa to go over some slides. I do also want to say I'm the Director of Substance Use for Los Angeles County, and on the board of NAMI California, as well as the son of a mother with schizophrenia. That's really what drives my work. It's why I became a psychiatrist. That's why I'm here in this group. And I very much appreciate the work of this group. I think your feedback is integral. As some of you, probably all of you already know, IPF is a $20 million per year for 5 years fund to invest in different aspects, different priorities that the state of California has, that we have, that was lifted up through Proposition 1. As part of that process, we've had listening sessions, we've had our Program Advisory Committee, or PAC, meetings to discuss in an open way, similar to this group, with kind of relaxed Bagley clean and relaxed rules around open engagement. We have collected feedback throughout the process, just to address a prior question, and staff have a pretty comprehensive compilation of it. And when we've provided updates through the different iterations, that feedback has been incorporated. I can talk to our staff, the CBH staff, about different ways just to make it clear what was incorporated. But I do want everyone to know that the feedback that's been received thus far, the feedback that will be received from this group and others, it's something that is top of mind for us. We know that there's a lot of interest in ensuring that these funds are invested in really high yield ways. I think we all want to see that. We also recognize, I particularly have highlighted, 20 million a year. It is substantial for a commission. We also have 58 counties across the state. So just, we're definitely not going to be able to fix all problems, which I think is another reason why there's a lot of interest in making sure that we're investing in the highest yield ways. So certainly understand that. And I think the last point I would just end with is, the last PAC meeting, we had discussed needing and wanting to move this to the broader commission for ongoing discussion, right, in terms of the IPF framework. And so it wasn't to close out the discussion, it was actually to continue discussion. Given the timing of it, if we didn't move it forward, the timing it's just been something that we've had to manage. So with that, I really appreciate being here. As you can see, I'm in between meetings, so I'm in my car right now. So as soon as I stop speaking, I'll be driving to my next location, but I would definitely be on for the entirety of the meeting, and I appreciate being here. With that, Melissa, do you want to take it away?
Yes, thank you so much, Commissioner Tsai. And thank you all for joining us today to focus on the Innovation Partnership Fund work to date. I see some familiar names and faces, so I know some of you have been engaging in our stakeholder and community partner process, and just really appreciate those of you who are here today and maybe hearing about our work on this IPF for the first time. So if we can get the slide deck up for IPF. And next slide, please. Okay, so Commissioner Tsai kind of mentioned some of these points, but just to briefly go over them by way of reminder. So the Innovation Partnership Fund was created by Prop 1 and is part of this shift from MHSA to BHSA. Under MHSA, 5% of total MHSA county funding was reserved for innovation projects. Those were developed and designed by counties and then approved by the commission. Under BHSA, this shifts from the counties to being state directed. The commission will be administering the Innovation Partnership Fund starting July 1st of 2026. And as Dr. Tsai mentioned, it will allocate 20 million a year for 5 years, so 100 million total. Next slide, please. So this kind of summarizes our timeline. It actually starts the timeline for the effort that we began over the summer, but the commission's work on the Innovation Partnership Fund actually started last fall with some targeted focus groups, and that resulted in a white paper that University of the Pacific developed. Then we held a commission meeting where we had a consultant from Sellers Dorsey help to facilitate that conversation. And at that point, we decided to do a series of focus groups that would be bookended by our program advisory committee meetings. So we held that our inaugural program advisory committee meeting in July, and kind of provided a draft of the IPF framework, got some initial feedback from committee members, and then launched into 3 separate virtual community engagement sessions over the summer and extending into the beginning of September. This lived experience session that you see kind of in the middle between August and September, we did invite participants from the listening session that this group, many of you participated in July, were invited to then attend the lived experience listening session, and we had great turnout and feedback and input at that time. So we just in the last couple of weeks had our program advisory committee meeting where we then summarized the feedback that we had gotten over those 3 community engagement sessions. We've revised and updated the IPF framework to reflect that input and feedback, and are here now today to really appreciate the opportunity to get your input on where we're at to date on the IPF framework. And then, as Dr. Tsai mentioned, for the October commission meeting, we'll be bringing all of this feedback to that full commission meeting and continuing this conversation so that when staff are writing and shaping the actual RFA, we will be able to incorporate what we've learned and heard over the last several months. Next slide, please. Oh, so it looks like there is some animation. Oh, thank you. Great. So one of the kind of core elements for the framework is landing on a definition of innovation. So what's currently in our framework that's based on the actual statute and language therein, we're defining innovation as a new or adapted approach to solving persistent problems in California's behavioral health system, especially those that relate to equity, access, workforce shortages, and service fragmentation. So these bullets after are kind of summarize how we're thinking about new and adapted and how we're thinking about strategies that really will help to shift and move the needle to help solve these persistent problems. So they can include advancing new models, tools, partnerships, or technologies, introduce or scale practical community-defined evidence-based practices that are evidence practices that increase access to prevention, treatment, and recovery supports. And I'm going to speak a little more to this prevention component in just a couple of slides. Third, that they be actionable and ready for real world implementation. That they demonstrate a clear break from the status quo, not simply incremental improvements to existing programs or efforts. And then finally, may include ideas from other sectors or geographies, adaptation of promising practices, or bold new models co-created with people with lived experience. Next slide, please. Okay, so now I'm going to get into some of the engagement efforts and what we learned. So as I mentioned, we had 3 community listening sessions, which included 321 unique community participants, which is just a fantastic turnout for us, but I think also really speaks to the level of interest that the community has in this the Innovation Partnership Fund work. We also did an open call for concepts earlier in the spring and received 49 submissions from community partners, CBOs, other state agencies, for-profit entities. So a good, robust response from that call for concepts. We've also presented and received feedback from other state agencies. So then we kind of have taken all of those, all of that input and feedback and tried to do a thematic analysis to try to kind of group the input and feedback into some focus areas, mechanisms, and outcomes. And all of that analysis has informed the framework as it is today. And we'll continue to iterate on that as we get additional feedback from community partners, state agency partners, and others. The RFP nuts and bolts are also getting informed by this process, and so we've started to craft, a very rough draft of an RFP that is informed by all of the comments and input and feedback we've gotten so far. All right, next slide, please. So it's difficult to, in just a couple of slides, sort of provide a really detailed overview of the feedback that we received. So I'm going to instead kind of focus on some of the themes that emerged through the feedback and conversations that we've had with our partners. So first, we have gotten a lot of questions and input about the target population. Who is the IPF meant to serve, meant to focus on, et cetera. And we've really tried to make sure that the framework and the emphasis is grounded in the statute. And in a couple of slides, I'll share exactly what that statutory language is. But a lot of the questions and comments have related to this target population. The next kind of broad area where much of the discussion and conversation occurred was around the definition of innovation. So how will we decide whether something is new or adapted, ready to implement, what sort of unpacking the definition of innovation so that it's clear to potential responders to an RFP what we're really looking for and how we're thinking about the IPF. A lot of that conversation also connected to cultural competence and wanting to really hold an equity and disparities lens as we're thinking about the RFP and thinking about the types of projects or strategies that will fund. We heard a lot of input around, not leaving out or excluding community-defined evidence practices. So that we've really tried to incorporate into the framework and subsequently the RFP. The other piece that these community input sessions, a lot of the input was occurred around what we had initially established as some pillars for the program advisory committee to kind of consider as we are hearing different projects and strategies of the commission's portfolio. And some of the input we received from the community was that by having a separate youth pillar, it seemed to kind of inadvertently exclude other populations that would benefit from strategies that the IPF could fund. So we've actually taken out the pillars and have instead tried to focus on really the target population definition and the kinds of mechanisms and outcomes that we hope to achieve through the IPF portfolio. Next slide, please. Some other feedback that we've received had to do with really making sure that the commission has an evaluation component to IPF, really wanting to make sure that we are collecting information for any of the strategies that are funded, that we're understanding what's working, what's not, so that we're really able to not only tell the story of how the IPF is rolling out as it's getting rolled out, but also what the impact was at the end of that 5 years. And that fits very nicely with how we're trying to prepare ourselves for, at the end of 5 years, we will be required to submit a report kind of laying out what lessons learned, the impact, best practices that emerged, et cetera. We've also had a great deal of conversation around how we're defining prevention and the types of prevention that can be considered, kind of connected back to the evaluation component. We got input on really having a data-driven approach. And so not only using data to inform and shape the framework and the IPF, but using data on then throughout the process and then on the back end to measure impact. Discussion around eligibility, who's allowed to apply, and really this, as I'll get into in a subsequent slide, this is open to CBOs, to for-profit entities, private nonprofits. I mean, it's really just an open field. There are some eligibility kind of constraints, again, around the target population, because we want to make sure that we're in line with what's articulated in the statute. We got input on scoring and just to ensure that that process is fair and objective, and then that any work that the IPF does is in alignment with state efforts to, again, move from MHSA to BHSA and implement Prop 1. Next slide, please. So as I mentioned, we decided to shift away from thinking about the pillars as kind of our one of the ways we're guiding the framework and the RFA development and eventually the selection of projects that are funded. Have moved away from the pillars towards thinking about these cross-cutting considerations. And these are elements that are in the statute themselves and feedback that we've received from commissioners, state agency partners, and the community as well. And so some of these I've already referenced, but really holding that equity lens throughout the entire process and focusing on projects that can really reduce disparities. Second is around finance and sustainability. So we really want to be thinking about sustainability from the very beginning of the funding process and make sure that that's part of our evaluation of proposals that will be scored as successful proposals. We want to make sure that there's sustainability built in from the very, very beginning, from the proposal stage. It's Next, we are interested in, because it's in the statute about this IPF trying to facilitate public-private partnerships, that, you know, by bringing together both sectors, we can really leverage the knowledge and expertise of both to help shift towards solving some of the most persistent problems in our system today. Next is advance effective treatment models. I think that's, you know, fairly straightforward. We really want to think about work that that the IPF can sort of seed and start, that will eventually be useful and be able to be picked up by the counties as they're working with clients and partners and the community. Lived experience and community leadership through this stakeholder process, and you know, in trying to situate the IPF as getting participation from those with lived experience and the community. We've, you know, this is why we're here today. This is why we did a series of community stakeholder engagement sessions, to really hear from those individuals who you know, potentially have the most to gain from IPF efforts and from the transition from MHSA to BHSA. I've already mentioned alignment with state efforts, so we don't want to just duplicate what other state agencies are doing. We want to align and be a value add to those efforts. Agility and quality improvement. This goes back to data-driven decisions and evaluation, and really creating a process where, if we're learning that things aren't working, that we're able to pivot and either work to improve as we go, or to be agile enough to pivot to a different strategy that may have more impact. And then lastly, leverage emerging technologies. And this connects to the public-private partnership, and just the idea that we want to be new and innovative and leverage expertise and tools that can really make a difference and shift towards solving problems and enhancing our systems and supports. Next slide. Okay, so now I'm going to talk a little bit about how we're trying to ground the IPF in statute itself. And so the next two slides really are to share with you how we've been thinking about prevention, and where we think that the IPF statute kind of points us to in terms of where on kind of this wheel we see prevention being, where we see IPF being able to have a prevention focus. So this is a really nice visual that the Institute of Medicine developed to really illustrate the continuum of care and the spectrum of prevention, earlier intervention, treatment, and recovery. So this is like the full wheel. And then if you go to the next slide, this sort of illustrates the components of prevention / early intervention that we feel the IPF is most suited for. And so that's really the indicated prevention part. So it's not prevention for you know, whole populations. It's really meant to target those individuals who may have some risk factors, who are, you know, have been identified as, you know, one example that I'll share is, you know, for those youth or students who may be exhibiting some behaviors in schools, like, you know, poor attendance or some suspensions and expulsions, behaviors that are triggering suspensions and expulsions. That would indicate some potential risk factors for subsequent either mental health issues or substance use issues. And so interventions that are targeted to that population to prevent behaviors and behaviors from becoming worse or shifting into more serious kinds of substance use issues or other behavioral health challenges. And then, we see that in addition to this prevention triangle that we're focused on, that the IPF can also support and dovetails nicely with the treatment and recovery component as well. And you all know more than anyone that the secondary prevention is so important once someone is in recovery. And so hopefully that helps kind of give you a sense of how we've been thinking about prevention in the context of IPF. Next slide, please. Okay, so again, this focus on our priority populations, this is what the statute says. And this is actually pulled, this language is pulled exactly from the statute itself. So we, legally interpret this language and the statute as, that the IPF fund must target these populations. So for the children and youth side, the population has to meet one of the following. These are not all. They don't have to meet all of these criteria, but have to meet at least one. So that they're experiencing homelessness or are at risk of being homeless, are at risk of being involved in the juvenile justice system, are reentering the community from a youth correctional facility, are involved in the child welfare system, or are at risk of institutionalization. And so on the adult and older adult side, similar kinds of components around homelessness, in or at risk of being in justice system involved, re-entering the community from state prison or county jail, at risk of conservatorship or institutionalization. Next slide, please. And then the BHSA programs and practices, this is articulated in the BHSA statute. And so we're trying to also think about, for IPF, how we can fund projects, strategies, programs, et cetera, that will eventually support the counties in their ability to stand up these housing intervention programs, full service partnerships, and then other kinds of behavioral health services and supports that are listed here, such as services for the children and older adult system of care, early intervention programs, outreach and engagement, workforce education and training, capital facilities and technological needs, and innovative behavioral health pilots and projects. Next slide, please. Some of the core purposes for IPF that we're starting to piece together, there are several elements. The first being that we really want to target IPF for the following. So to improve BHSA programs and practices for the following groups: underserved populations, low-income populations, communities impacted by other behavioral health disparities, and then per the statute, other populations as the commission determines that again are still nested within the populations listed above, but that can be further specified by the commission. Next slide, please. And then the second element is that we want to situate IPF to meet BHSA goals and objectives. These goals and objectives are to reduce identified disparities. They're established and defined by DHCS in consultation with the commission, counties, and stakeholders. So this is how we're considering being data driven, thinking about evaluation from the beginning, thinking about sustainability from the beginning, and really holding IPF as one tool to support the implementation of Prop 1 in order to meet its overarching goals and objectives. Next slide. And some of those goals and objectives we list here. So on the left, the BHSA goals, as specified in statute, are to prioritize people with the most significant needs, to integrate mental health and substance use disorder treatment, expand housing and community-based services, grow and diversify the behavioral health workforce, advance equity and reduce disparities, strengthen oversight, transparency, and accountability, and support early intervention and prevention. So you can kind of see there's commonalities in the language that is articulated here, and the cross-cutting considerations and the way that we're thinking about our priority populations. And then on the right are the DHCS statewide population goals that DHCS's Equity and Quality Committee has been working on for the last several months, and on which the commission is a member of. And so we've been a part of these committee meetings and have been weighing in and providing support to DHCS. So they are to reduce negative outcomes such as suicide, overdose, homelessness, justice involvement, and to increase protective elements such as care experience, access, prevention and treatment of co-occurring conditions, social connection, etc. Next slide, please. So in sum, and I know that's a lot of information to take in, so I'm kind of eager to get to the discussion part of this so that I can hear from you all and can stop presenting and talking. But in sum, the BHSA intent language for Prop 1 clarifies that the modernization of MHSA is to focus funds on where they're most needed, expand services to include treatment for those with SUD, and prioritizing care for those with the most serious mental illness, including the disproportionate number experiencing unsheltered homelessness. So together, these provisions provide a clear statutory mandate that Prop 1 funding, and specifically IPF, must be directed to those populations with the highest behavioral health needs who often face structural barriers. So IPF projects must align with these broader Behavioral Health Services Act goals and demonstrate innovation in serving eligible priority populations as defined in law and as I talked through a couple of slides ago. Next slide, please. So next steps are, we're continuing to engage. We're continuing to talk with state agency partners that are mandated by IPF, so agency, DHCS, CDPH, and HCI. As we mentioned, we'll be providing a recommendation to the full commission, providing a recommendation / inviting further conversation and discussion during the full commission meeting on October 23rd. And with the goal, and Dr. Tsai kind of referenced, kind of this tight timeline we've trying to have been working within in order to be ready to release the funds July 1, 2026, so that the projects can start. We are looking at being able to present an RFP outline to the full commission in January of 2026. And then upon approval, we'll be able to start that competitive procurement process, release the RFP, do the scoring and whole process so that we're ready to make those grant awards by July 1, 2026. So I think that is the end of the presentation until we get to the actual vote. So I will pause here and maybe first invite Commissioner Chambers or Commissioner Tsai if they want to make any comments before we open it up to you all. So thank you so much for letting me share this presentation with you.
Thank you, Melissa. You just always do so well in informing us. I learned more stuff on the wheel and just how my ideas were spinning. I want to thank Dr. Sai as well for joining this conversation, and I will leave my comments and let the public, well, the committee. So unless Vice Chair Alvarez has any additional comments, I will at this time. Okay, cool. At this time, I would like to invite committee members to offer comments and ask questions. This is the time to give us all your insights on this presentation and our focus of how these funds will prioritize and the populations where the buckets of funding is prioritized under the new BHSA. And I would like to get insights on how we can, how you think we can influence those priority areas where like equity and, you know, lived experience and public-private, other things. I'm not looking at the slide, it's just off memory. But yeah, this is what I've been waiting for the last couple weeks. So I know the presentation was long, but does committee members have any input, or you just agree and we take a vote?
Are you opening public comment?
Well, it's the committee members' comment,
Yes.
right?
Yeah.
Or,
Committee members. Yes. Yes.
no? So no committee member. Oh, I see Jason's hand. Oh, and then I hear Sinai.
Yes.
I don't, okay, so let's go with Jason first, committee member Jason. And then we'll go to you, member Sinai.
Thank you, and thank you very much for the presentation. I guess my first question is I'm going back to the deck that I have in my materials. So the slide that is BHSA programs and practices talks about the housing intervention programs for chronically homeless and for capital development projects as specified. I'm just looking for clarity. So are we thinking that the innovation project funding will support people in those projects with services, or are we saying that innovation funding would also go for the capital development projects?
I don't want to answer the question, but I'm hearing that we're supposed to be focusing these funds on enhancing those three buckets. So those three buckets are housing, full service partnerships, and then the services. Treatment.
I can weigh in here too. Jason, appreciate the question. My understanding is that there's a desire to avoid as much duplication as possible if there's already investments being made. And so I don't think the idea is that these funds would be used for things like capital, which we know one project could easily eat up the entire amount. So hopefully that addresses your question. I think also at this stage, I don't know that we want to narrow it in the investments so much where we're boxed in, but I do think that the statute and also just conversations we've had with various folks at the state make it pretty clear that there's a desire to make sure this money is stretched and that we're not just duplicating things that are being invested in elsewhere.
So Dr. Sai, just for clarity then, so are we enhancing or in it like so those buckets are priority buckets. We don't want to duplicate them. Are we enhancing them to innovate them to be better?
So I think that's a great question, Chair. I think this is where, words matter, which is what you're getting at, and I agree. I think enhance could be interpreted different ways. I would say something, I would probably use a word similar to compliment, right? But I don't know, Sandra, if there's anything more legalese that you would recommend in terms of how we think about this.
Yeah, I'd have to give it a little bit more thought. I wouldn't want to misspeak publicly right now, but I think that you were on the right track.
So
okay.
To your point,
I would just say
okay.
in response to thank you for the explanation, because one of the concerns that has come up in my local planning process around BHSA is the heavy cost of capital development for housing and the lack of funding for supportive services within that. So, and I understand especially at this point, the desire to be kind of broad and to not rule anything out, because there could be ways of, for example, enhancing the options that people have for moving into housing that's not necessarily capital development, but we don't want to rule anything out. And I think if the goal is really focused on increasing, services in those priority populations and the outcomes, I think it works. So thank you.
Thank you for your comments, Chair Robinson. I'll go with Chair Admasu. I mean, not Chair, committee member.
Thank you. So I'm going to use my phone. I'm having difficulty here. So my question is the definition of underserved population. Like within MHSA, it was a little bit more the marginalized communities. They don't have to be homeless. They don't have to be incarcerated. All that definition, what it has, it would be inclusive. Right now, it's specific on this category. It looks like early intervention. How do we even add community defined practice if we don't identify being inclusive those underserved communities? So I think I'm a little bit off of the definition what included.
Thank you. I mean, I know there was some discussion in the chat about other populations at risk. Was underserved in statute just for the staff? Is that? Yeah, it is.
Yeah, those slides that discuss the priority populations and then the BHSA populations, we pulled that language directly from the statute.
Does it say? I mean, I guess tonight, you want clarity on, like, because they give the specific underserved population that they want to focus on, right?
Yeah, so right now I was looking at the list of underserved population. It's a homeless at risk or incarcerated. All that is more, even to be an institutionalization. So all that I understand, but again, MHSA used to be some immigrant community who are barrier languages or culturally different. And those are underserved communities. At least that's what we define them. Now it's not included. So if they're not under homeless category or at risk, this sounds like more individual than the whole community as one. This categorize or definition of underserved. That's what I'm not really clear. What does that mean for other communities?
I hear you. Melissa, do we have any, is statute say, or Sandra, is the statute say anything about like marginalized ethnic communities or?
The statute, and I'm looking at the slide from Melissa's presentation that's titled Focus on Priority Populations, that is coming directly from the statute. So that is where, yes, and I think they're putting it on the screen right now, where this is what the statute says is
nothing about other like cultures. So I mean, is that something that, I'm not giving ideas, I mean, but is that something we would probably want to highlight potentially, Vice Chair, like if statute doesn't call out, I mean, this is not our decision, but I mean, at least recommendations or highlighting like I don't know. I mean, if it doesn't, I mean, or do we even, is that something we want to take up? Or I don't know if this is not our decision, it's just more a conversation. If, you know, this like historically marginalized ethnic communities, which I mean, I've been a macro practitioner for a long time. And I mean, I've historically described at-risk population, underserved population is as historically,
Right.
yeah.
I want to be mindful that there's a lot of comments, but I will just say,
Okay.
Chair Chambers, I think this is the crux of the issue, right? There is a shift with BHSA that many of us are very concerned with, very, very concerned, myself included. But it is a shift that was passed and that is now being enacted. So the discussion is the commission's then responsibility to implement this shift while also being a champion for what we are hearing and where we can champion that, right? Much of the prevention and early intervention discussion has shifted completely away from commission to the Department of Public Health. And so there's opportunities to raise that in other areas. But I think this is the crux of the issue, is this shift.
Thank you for highlighting the Department of Public Health as well. And we can just keep these in the comments and then we'll hold ourselves accountable. The next, Amari, somebody got to help me with the hands, but I don't know if it was committee member Ayala next and then yeah, okay.
Yeah, let me
Keep me honest.
Okay, yeah. First we had committee member Ayala.
Oh, okay. Thank you. I thought it was somebody else. So first, I appreciate the clear emphasis on equity, lived experience, and community leadership. Those are essential if we want the innovation relevant and trusted by those with the highest behavioral health needs. What I wanted to get clarity on was I saw the definition of innovation, and the draft frames innovation as a clear break from the status quo. And it would be helpful to clarify for me whether the projects that adapt and scale existing local models statewide versus creating something entirely new are considered innovative.
I mean, I want to see if Dr. Sai has any, not that I'm putting you on the spot, but I mean, I think that that's a fair question. Like,
yeah, I think because there's many community-based approaches that are proven but underfunded for replication. And so clear guidance could avoid confusion during like proposal development and that. And if that makes sense.
Yeah, thank you. Definitely not putting me on the spot. I deserve to be on the spot because of my role in this. So I do appreciate the question. Carolina, let me know if I'm not understanding in my response where, at this point, we've heard feedback about wanting to include community defined practices and kind of other more broad approaches. And so we've done that in the latest iterations to be more clear about that. But I may have missed the earlier part of your question. So let me know if I missed anything.
you're talking about expanding models, right, Caroline? Like, is innovation expanding models that are currently underfunded? And maybe you answered that already.
So there is language that we've gone over in prior discussions about essentially scaling things that have been demonstrated to be high impact, right? So I think that's what I interpret when I hear your question. It's not necessarily just new. It's also if there's something that's good that's only being done in a small area because of whatever reason, in this case, maybe lack of investments or whatnot, this is something that potentially could be invested in to try to address that.
Okay, thank you for the clarification.
And obviously, Melissa or Sandra, if I'm, saying anything that sounds off, let me know.
I don't know. It sounds right to me, Dr. Sai.
Yes,
I mean, I just think that aligns as like a macro practitioner and someone like I feel like there is new opportunities to learn new things, AI, but there's just also a lot of good things that are happening in ethnic enclaves and peer-run organizations and smaller projects that just have not been funded or can be scaled. Okay, I'll keep it going because we're short on time. I don't know if it's committee member Dara or Jason or
it was actually, yeah, it was committee member.
I've gone before, so I'm happy to take a back seat to other committee members. Okay. All right. So I just want to say, I'll try and be quick. I know that, it doesn't serve anybody to be over prescriptive. At the same time, the concerns about BHSA are not just that community-based practices are being left out, it's that the community is being left out because the transition incentivizes scaled organizations that are able to bill under Medi-Cal, right? And so other state proposals have prioritized in their RFA process specific things like a community-based organization, a peer-run organization, a family-led organization, an organization led by a marginalized community. And I think it would be important to include a way of bringing that into the scoring process that looks at the makeup and the history of the organization itself rather than just the practice.
I think you're so profound. Everybody's profound here, but I think as long as I can serve under our governor and support the policies, but until like a fine balance of the truth, like how do we implement this law and folks like us in this room don't get left behind? And I think that that's what we're hearing. I mean, I just like this is what's happening already. Like, us, we're, I don't know. It's not preaching to the choir, but I hope that we can keep that language of, ethnic run, woman, led or client consumer run, because as we see more counties are transitioning peer run services or operated wellness centers into other models. So we won't know what community-based organization programs, small programs are going to look like in the next couple of years with this transition. So I want the commission to continue to uplift that work while we're trying to implement this law. Okay, go ahead. And now, I got to get my little points in it. Go ahead, Eugene.
Right, Chair. Sorry, Chair. Can I make a point on that just to
Please go ahead, Doctor.
I appreciate that comment as well. One of the things just in this discussion I want to highlight is that like some of what we're discussing is actually more kind of feedback on BHSA as a whole, right? And so I just want to make sure that, I think the focus on this agenda item is going to be, general agreement on moving this forward for broader discussion within the commission, because IPF is obviously not, and we're not going to have any authority to change BHSA. So I just wanted to make that point.
I think that gives hope. Like, I think, like, as someone that is a public administrator, public policy administrator, that's the science, right? You have to be able to give feedback on the data or what's happening on the law, or then what's the point of doing this, right? We can't, so I really respect that, Dr. Sai, and I really hope that we can uplift it while working in partnership with agency to implement this law, but also listening to the people as well and how we can bridge. Like, I'm a bridger. So thank you for that. That gives me a lot of hope.
Yeah, I'll just be really brief in my response because some of the sentiments that I wanted to echo have already been echoed. And Dr. Sai, I definitely appreciate, that point of, this is relating to, IPF and the difference and also just the policy overall for BHSA. As a person who, as our BHSA coordinator and having to, inform agencies that they do not, meet the criteria for eligibility for BHSA, it hasn't been a fun position to be in. And many of these agencies are, grassroots organizations that are extremely valuable, to communities. And so anywhere where we could be clear in the ways and opportunities for organizations like those to have opportunities to redefine or reimagine their work under these new criterias for the expectation for funding under BHSA. I just would love to uplift that and if we can explore, and really providing, concrete examples of what that could even look like for a, mom and pop, organization. Because oftentimes, one of my previous managers, who some of you all may know, Tracy Lacey, she always used to say, like, the answers don't, like, we sit in these buildings and these offices, like, and we try to explore, what those solutions are, but the solutions don't really live here in these offices, in these buildings. They often live in the communities, that we're gathering, feedback from, or these grassroots agencies, who have actually done a much better job of reaching at-risk and hard-to-reach individuals, or often are situated, directly with them, in partnership with them, and those we are attempting to serve, right? And so so it's not really a question, but rather, just an ask of, if there are opportunities for us to be very clear in what that could look like. So when a mom and pop, reads this opportunity, that we spread through emails or other means, like, it can be clear, like, oh, this is an opportunity that I can, as an agency, apply for, because the work I do is valuable in those ways and can be billable.
To your point, Eugene, I just want to thank you for, as a county, I know you're not speaking for the county per se, but just as a worker, this is what we're seeing already across the state, that small CBOs are looking at these all, and they're not just mom and pop. They are $3 million, $2 million, peer run, black, brown, like organizations that are run, that do not fit these qualifications. And I think the advocacy, we're trying to work, I want to work in partnership with the agency, but also be that voice. And I had been saying this, 2 years ago, when I was like, oh, I still don't meet these qualifications. So I think that, I hope that us as a commission, as we try to work in partnership, that we also hear these voices, even hear everybody comment, but your comment specifically, because you're seeing it on another side, what we have been seeing. And a lot of us as consumers and clients and people of color are like, where does our voice come in, and where do we get to practice? Where do we get to serve? Because we want to serve. And I'll go, I don't know if it was committee member Owen that was next, Mariani or Sandra, but I don't want to.
Yes, it was committee member Dura. Sorry if I just said that
Just
wrong.
went already.
Oh, okay, sorry, let me lower his hand. Then it was committee member Owen.
Thanks. I'll be quick. I really appreciate following Eugene, because I feel like I'm sort of repeating it, what he's saying in a slightly different way. But, often there's barely enough funding for service delivery in these kinds of projects, which means evaluation becomes mostly head counts. And it really leaves out, piggybacking on what Eugene said, reaching harder to serve and those in the most need. You don't get that knowledge with those head counts. And then sustainable impact measurement, when you have very little money, you don't really know those mom and pops that are doing tremendous work that could be replicated in the same type of community or that same type of population. And then even what I find just non-existent a lot is after discharge, 6, 12, 24-month follow-up. It's very minimal money to be able to say, can we look at this, and what happened? Did they go back into the system? What happened with them? And there just isn't enough money because of the service delivery money. And sometimes county staff say, we're going to be doing the evaluation. So, we don't need this program to have any outside evaluators. But I know BHSA promotes outside evaluators. And sometimes they have limited population knowledge or community knowledge. And I appreciate Eugene saying what he said. I think knowledge development and dissemination is critical. And although sometimes we say we disseminate because we did a couple numbers and we gave a little paragraph, we don't know. And it could bring about a wider impact, what works for communities and populations. But most importantly, we want to know what doesn't work. And we want to feel really comfortable saying that we did an innovation project and what didn't work. And so we had to course correct. And, we want to be able to say this didn't work for this population. Our words were wrong. Our language was wrong. Our approach, our measurement, our intervention. Let's say that. And let's feel comfortable enough to invest in outside evaluators to do that.
I think Jim.
Very much.
Go ahead, sorry. Committee member Owen, were you done? Okay. I see committee member Ayala. I don't know if we have.
That was it. It was a committee member Ayala is the last committee member.
Okay.
I keep seeing a hand up for, is it committee member Lay?
I don't know if that's a committee. I think
Public
that's a public comment.
Oh, okay, understood. Thank you. So thank you for the last two. I kind of piggyback off of that as well with under technical assistance and capacity building, right? That the fund I believe has the potential or could actually unintentionally favor well-resourced organizations unless it explicitly builds capacity for smaller, emerging, and culturally rooted CBOs. And so I think in that is that we, that we ensure that there's going to be support, maybe like even in the evaluation, is it going to be standardized? Like, can the commission support in that while still allowing CBOs to have their own, the smaller community have they don't have data sophisticated teams, right? Like we don't have these, there's a lot of CBOs that don't have this, and considering providing reporting templates, training, possible funding for evaluation partners that all can comply with and then actually see impact across the board. So perhaps having support in that while still allowing flexible innovation space around like cultural healing outcomes, peer leadership development, youth engagement levels. So having both and as a support, if that's something, that could be considered also, if not already.
I think that's good, and we'll put it in the notes. I think that we need to build the capacity of everybody, and well-funded organizations should be building the capacity of other organizations. That's the way that we would sustain our system. Not everybody can just do it on their own. All right. I think that now that we're done with committee member comments, we'll like to move right now to public comment and open the dialogue. Amariani, please go ahead.
Thanks, Chair. At this time, members of the public may request to make a public comment on this item. We currently have a few comments. Our first comment is in the room from Danny. You can go ahead.
You funded this company?
Sorry about that. Please go ahead.
Perfect. Thank you so much. Good morning, commissioners and committee members. My name is Danny Therical, Public Policy Coordinator with Mental Health America of California. I want to first thank the commission and staff for their hard work thus far on this Innovation Partnership Fund framework. I'm here to share our recommendations for the fund and framework that we believe this committee should consider and propose to the full commission. First, changes in the BHSA allocations have significantly limited the revenue available for behavioral health services and supports, formerly known as the community supports and services. This requires counties to essentially do more with less. The IPF presents an opportunity to support county programming in these areas while innovating to meet the needs of the community. This framework should prioritize investments within the BHSS component of the BHSA. Second, the limited funding for BHSS also means that partnerships between counties and local CBOs are going to be extremely important. CBOs have a pre-existing relationship with the local community. They can help bring in additional funding to support county programming, and they provide a unique perspective for the population they serve and are able to identify innovative solutions for their community's needs. The current framework does not mention community-based organizations once. It does mention community-based services and community-based providers, but that is not the same. And so that should be called out in the framework. Third, to support local CBOs, we also recommend that the Commission implement small-scale funding grants. Many of the innovative solutions that local CBOs come up with don't require large financial investments. Many of the innovative solutions can be accomplished with smaller investments between $50,000 to $250,000. We would recommend that these grants also be distributed via an application process versus a request for a proposal to help with administrative burden. And then finally, the current framework lacks clarity on which population the Commission has determined will be served under the IPF. It also does not outline the process the Commission will take to make such determinations. The BHSA allows CBH to identify these other populations. We just request that the framework indicate how the Commission intends to do so prior to the release of proposals or applications. And then furthermore, we would also request that the following populations actually do be included: our transition age youth, our LGBTQIA plus community, and our immigrant and refugee community. We believe that these 4 recommendations will enhance innovation for the BHSA component in need of most support, the BHSS, and improve access to grant funding, ensure coordination with local stakeholders, and ensure populations with significant behavioral health disparities are not excluded. Thank you.
Thank you. That was our last in-room comment. Moving to virtual comments, we have 6 currently. Our first comment is from Eba. Your line is open.
Thank you so much. I'm Abelaye, president of Whole Systems Learning, and I'm also an attorney. So when I read all the slides, I went immediately to the WIC code. And if you could bring up the slide that says focus on priority populations. It says 5945.1C. There is no 5945.1C. However, in 5963, it defines that. However, 5963 only applies to the integrated plans for the county. It does not mention underserved, it does not define underserved. It does prioritize the populations there. Now, if you go to the slide that says IPF purposes first element, and that, because 5892 is only very general. Now, 5845 is what defines those populations. It speaks specifically to the Innovation Fund. So those are for the Innovation Fund, the priority populations, and underserved would have its traditional meaning. And just to repeat myself, if you go to code section 5963, that does not apply to innovation. This is the only one that applies to innovation, and that is 5845. So I think that if we're going to follow the law, we need to separate the confusion between 5845, which is this slide, and 5963, which is the other, because the other for the homelessness does not define that as an underserved population. And I think we need to follow the law.
This is Sandra. I just want to clarify that the statute, the IPF statute is 5845.1. And it is listed, that is basically the language that's on the screen right now that says underserved, but it says that it should be funded pursuant to WIC 5892A, which is referencing the county programs. 5892A is the 90% of the MHSF BHSA budget that goes to the counties, which must be focused on 5892D, which is the priority population. This is like letter and number soup, I understand, but know that we are grounding our legal understanding on the fact that the statute as it reads is that it has to be funded pursuant to the county groups 5892 and 5892D. It lists out the priority pops. So
5892D, but if you go to 5963, okay, so does 5962, does 59?
we're only working with 5845.1 and 5892 are the two relevant statutes.
5845. Okay, I'm going to go look that up, and then
and
I'm going to
5892. So 5892A spells out the county programs, and D is what spells out who the county must prioritize. And if you see the IPF statute, which is on the screen right now, it refers back to the county programs.
Okay, is that all right if I look at 5892 and raise my hand again?
Yes.
Thank you.
Our next comment is from, and I'm sorry if I mispronounced your name, Maran. Your line is open.
Thank you. My name is Meron Gonifer. I'm the Policy Director with Cult Voices. I enjoyed Dr. Melissa Martin Mollard's presentation. Thank you for highlighting in the presentation the importance of aligning the behavioral service goals, services related to reducing disparities, and objectives with measurable outcomes based on data. I think this approach is crucial for ensuring that funds are allocated to programs and services that have been proven effective. It also maintains a dynamic and innovative process. Also, I appreciate the emphasis on considering lived experience and community leadership as they are crucial. We hope the Commission focuses on identifying and funding innovative consumer-run organizations such as peer-led organization as part of empowering community leadership and organization. Thank you.
Can I go again?
We will come back to you in just a second. We're going to go back in order. Our next comment is from Laurel. Your line is open.
Good morning. I'm Laurel Ben Hamida with Muslim American Society Social Services Foundation in Sacramento and REMCO. And I wanted to just mention a few things. I'm sorry for those that were there at the last meeting that I spoke about in the other committee meetings a week ago, because some of them haven't been mentioned here. One is that we don't really have a clue yet what size projects are being considered, what size limits are, either too small or too big. We don't know that what the RFP process is going to look like, but I suggest that the staff and commission look at doing what the Department of Public Health did for the CRDP project, which was an expensive project and multi-year, and they let out the RFP for review by community-based organizations and others before the final and comments, and then went back and revised, and that influenced and made for a better RFP coming out. I am wondering about the prospect of a 5 years, $100 million, and yet I don't see a 5-year overview plan yet. And it struck me that that is maybe something that should be considered, not just year one and done. It needs to be tied into other years, and that we really haven't discussed that so far. But I wonder if a proposal for a 1-year project with a 5-year plan included in it would be one way for community-based and other larger, not community-based organizations and corporations to have their input into a successful plan. Last meeting, Josefina from Alvarez from, I'm sorry, I am really, okay, let me start over. From Safe Passages suggested more money for evaluation, at least 20%. That makes a lot of sense to me because this is an expensive project. The money might not be there next time. And we need to know, we need not to have the kind of evaluation that some of the speakers today have suggested, but a very, very good and rigorous evaluation, maybe with local evaluators and maybe with a statewide evaluator as they did with the CRDP. Because then you have something you can really sink your teeth into. And I would also say that recently Care Court talked about their brand evaluation. So they're having 1-year evaluations and then a large evaluation by RAND. And I observed some shortcomings in the amount of funding for that, which meant that they said there were not enough funds to go past languages of English and Spanish speakers in terms of looking at community-based feedback of how Care Court has rolled out. And to me, that's a big shortcoming. It's good to have Spanish, but they should have enough money. RAND can do it. And any evaluator that you would pick would presumably be able to do it, but they do need money. It's expensive. I wish that we had more conversation going. I think that this is part of easing into this new committee, but it seems like it's still very artificial. So I would just like to see if I can ask Jason, for example, a question. So Jason has said some things, and he's also involved in a peer-run organization. Do you think that there's a place in this money that's going to be let out to be spent on coalitions of community-based organizations which maybe already have peer support, and clinical could be pulled in and developed, and because there's such a shortage of clinical people who speak other languages, they might have to be shared among other members of a coalition, and that these organizations could use their CDEPs as part of treatment. So peer support as part of treatment. I don't like the fact that I hear all the time that peer support's really valuable in treatment when clinicians and peer supporters play well together and work well together. So that's my question for Jason and anyone else who would like to have a conversation today. Thank you.
I'm just following the order. Do I answer or before going to the next public comment, or how do you want to proceed?
Yeah, it is open conversation, so you can feel free to answer.
Yeah, well, I really appreciate the input, all of the input from many people. I think some of the ideas are great. I can't speak directly to what the RFA process is as a committee member. I don't know. It's still being determined. I have to say, upon looking at the slide deck, one of the things that came to mind for me was an opportunity for a statewide coalition of community-based providers to apply together. I think that would be a great innovation. I don't know how it would be scored, but it's something that that interests me. And I don't know if it could be, I don't know if it could be called out in the RFA process that coalitions of community-based providers would be considered. as applicants. I think that language could be put in the RFA process, because many RFA processes set eligibility for who's eligible to apply. And a coalition of community-based organizations would be a good way to make sure that that's in there. And I hope that answers your question.
I hear we need to build coalitions, and that's something that I think is necessary in general. Go ahead, Mariani. I don't know
Yeah, sorry.
how many comments we have.
Okay. Our next comment is from Stacy. Your line is open.
Thank you. Thank you. Stacy Hiramoto with Remco and Safe Passages. I'll try to make it quick. First, I really do want to acknowledge and thank the staff and the commissions, because I feel that you're listening, because your latest draft of the V3, the actual document, does reflect many of the things, such as getting rid of the pillars. Moving on, if the chat were open, Commissioner Chambers, you asked about the language. This was very frustrating because you asked if the language about underserved, low income, are those, people experiencing disparities. As Eba Laye pointed out, it is in the statute under section 5845.1. I support Danny Thirakul's comments on community-based organizations, those points specifically towards community-based organizations. Moving on, an RFP put out by the state can be, I know some of the commissioners were told otherwise by people who are no longer at the commission, but people who are not state workers can be put on those panels. So I know that some commissioners were told otherwise, but that person's no longer with the commission. And yes, I do think that you need sometimes people with expertise about CDEPs, about serving underserved BIPOC and LGBTQ communities. Laurel, it was DMH, not CDPH, that did this. And so again, it is legal. And also Brenda knows this, that it is legal to have people, not only state workers, on these panels. The last thing I want to talk about is much of the presentation, again, seems to be saying that they're focusing on the sickest and the people with the most need. However, I want to remind people, BIPOC and LGBTQ plus communities define underserved and those with most needs probably different than what the general population defines that. And of course, we acknowledge that the authors of Prop 1 want to prioritize people with, quote, serious mental illness. However, there is no requirement of having a diagnosis to be served in the components of Prop 1. And there is no prohibition of serving those that do not have a diagnosis. Prop 1 funding, specifically the IPF, must be directed towards those populations with the highest behavioral health needs who often face structural barriers. That's what's in the law. But what I'm worried about is that CDEPs do not limit their programs to people who have a diagnosis or may be, quote, the sickest. They often include people from the community, anyone in the community that wants to participate. But this does include people who are at risk or have serious mental health conditions. So the RFP must allow mixing of these people and not require only those who are in those very defined categories. I'm sorry, thank you.
I'm popping in. This is Sandra Gallardo, Chief Counsel. It is 11:02. I see 3 more comments on the string. We can take those 3 comments, but we will have to adjourn after that because the meeting has not been noticed to go beyond 11 a.m. So I want to make sure that we close public comment from the other than the 3 that have their hands raised so that we can continue to abide by the Bagley-Keene.
Thank you, Sandra.
Next, we have a comment from Ash. Your line is open.
Good morning. My name is Ash Wilhelm, and I'm a graduate MSW student and intern with Safe Passages. I want to speak today with deep respect for the work behind this framework and with equal urgency about what still needs to be addressed if the IPF is to meet its stated goals. The record shows that CDEPs were the most frequently cited stakeholder priority in the Commission's own community engagement process. Yet without structural safeguards such as equity-based scoring criteria or dedicated implementation standards, these practices remain vulnerable to being sidelined by the systems that have historically underserved our communities. So I just want to urge the Commission to consider developing clear equity-based evaluation criteria and transparent reporting structures that ensure counties are held accountable to the stakeholder-defined priorities, including CDEPs. Thank you for the opportunity to speak.
Thank you. Next we have Sarai. Your line is open.
Good morning. My name is Sarai Soto Talavera, she, her pronouns, and I'm a Master's of Social Welfare student at UC Berkeley and also an intern with Safe Passages. As many community members shared at last week's program advisory committee meeting on the 18th, I also share the deep concerns about how the proposed IPF framework, the version 3.0, does not explicitly prioritize the BIPOC or LGBTQIA plus communities, nor does it explicitly prioritize community-defined evidence-based evidence practices, CDEPs. While they are mentioned, failing to prioritize these explicitly in the framework is incredibly harmful and has the potential to impact funding for CDEPs and the CRDP altogether. As Commissioner Tsai mentioned earlier, words do matter, and the lack of specificity could lead to funding loss, which would lead to an increase in the acuity of mental health needs, barriers in accessing care, homelessness, involvement with the justice system, etc. This would be catastrophic and could cause even more harm and trauma to our BIPOC and LGBTQIA plus communities, which is the opposite of what we're all trying to do, and it's the opposite of BHSA's goals and the goals of DHCS. And so, I really urge that y'all don't follow what the program advisory committee did last week, where they voted to recommend the adoption of the version 3.0 framework, despite the overwhelming concerns that were brought up from the public. And so I just really urge this committee to listen to what we're saying and to listen to our concerns and to not vote to recommend the adoption of the framework until these concerns are addressed. Thank you.
Thank you. And then our last comment is from Eba. Your line is open.
Thank you. I probably wasn't clear before. 5845 is the only place where it is defined, the groups are defined. There's nowhere in the act that underserved populations are defined as what it says on the slide on focus on priority populations. There's nowhere that defines underserved like that. The only underserved is on this in IPF 5845. And if we focus on 5845, we cannot define priority populations as chronically homeless or experiencing homelessness and what's on that slide. Those are not the priority populations. They are not defined. That is not the definition of underserved. And the only definition is what's in 5845.
I do want to enjoy, and I can communicate offline with you, Eba Lay. It's in 5892D, which is cited by 58. We can move this conversation offline so I can show you where the priority populations are defined in statute.
Okay.
And I'm sure that Sandra, they always do get back to folks when there's a direct.
How do I reach you?
At your registration, the email you used for your registration, I will get it from our staff and I'll send you my communication directly for us to hop on the phone.
Oh, okay, thank you. Because looking at 5892D, I don't see it.
I appreciate, this is what we need. We need you to keep coming back, Eva, and working with Sandra, and we need as many advocates as possible So Mariani, was that the end of public comment?
Yes, that was our last
Thank-
public
thank-
comment.
Thank you. Thank you. Now that public comment is closed, I would like to take a roll call to vote for the CFC Advisory Committee to recommend the adoption of the IPF Framework 3.0 to the full commission. I would like to remind everyone that our committee is advisory in nature, so a vote is a symbolic agreement that we support using this decision-making framework. Now, I would like to entertain the motion for that the Client, Family, and Community Inclusion Lived Experience Diversity Advisory Committee recommend the adoption of the Innovation Partnership Fund 3.0 to the full commission. Do I have a motion or?
It's a symbolic motion. This is, again,
Symbolic.
this is a symbolic motion.
Do I have a symbolic motion?
Can you clarify what a symbolic motion is?
I can pop in and say, because this is an advisory committee can only advise the full commission. Only the full commission can move and adopt anything because they're the ones who are statutorily appointed by the governor and other appointing authorities. The committees, all of them, the PAC, all of the other committees that we have 5, exist only to advise. So if we want to make an actual formal recommendation to the full committee, we're emulating the motion and seconding process. But again, all of this is symbolic only in nature because only the full commission of 27 commissioners can actually act on behalf of the commission.
Okay. In that case, can our symbolic motion include a friendly amendment that includes some of the input we've received where our recommendation is to improve with modification so that the RFA process incentivizes and emphasizes community-run organizations and practices?
So community, can you say that again? Incentivizes community?
Yeah, emphasizes and incentivizes the use of community-run organizations and community-based practices.
Yes, you can make a symbolic motion to adopt the framework with the added, so the yes plus, right? Yes, we accept the framework plus if we can add an emphasis and incentivize community-run organizations and community-based practices. Is that correct?
Yes.
Yes, and you would need a second.
Okay.
A symbolic second, I guess.
The floor is open for a symbolic second to say aye.
Aye.
Can I say, who said that? Who said that? I need to know.
Carolina Ayala. Oh.
Ayala?
Yes.
Perfect. So we have a first and a symbolic first and a second motion. I will read the motion out before I call out your committee names. It's for the Client, Family, and Community Inclusion Lived Experience and Diversity Advisory Committee recommend the adoption of the Innovation Partnership Fund Framework 3.0 to the full commission with added recommendation of an emphasis in incentivizing community-run organizations and community-based practices. I have a first from committee member Robinson and a second from committee member Ayala. I am now going to call roll. Please, committee members, please unmute your lines and be ready to give a yes or no or abstain. Committee member Adamasu.
Yes.
Committee member Ayala.
Yes.
Committee member Chavez. Absent. Committee member Dura.
Aye.
Absent. Oh, aye. Okay.
Yeah.
Committee member Gansweg. Absent. Committee member Gilmer.
Yes.
Committee member Kayali. Absent. Committee member Krishnowski. Absent. Committee member McFetter. Absent. Committee Member Novotny. Committee Member Owen.
Yes.
Committee Member Robeson.
Yes.
Committee Member Zhang. Absent. Committee Member Zaldivar.
Yes.
Committee Vice Chair Alvarez.
Aye.
Committee Chair Chambers.
Aye.
The symbolic motion passes.
I just want to thank everyone. Right, I think this is the last agenda item, right? Oh, yeah. Now we've come to the end of our meeting. Thank you all. Thank you all again, our committee members, for being here today, and the public. A huge thank to the public and the other commissioners and staff for your thoughtful engagement and support. Our next committee meeting will be in November with the specific date to be determined. We will send out an email to our BHS OAC email distribution list with more information in the future. With that, I will now adjourn the meeting. Thank you all for your time. I really do appreciate your time. Thanks for your insights and commitment. We look forward to continuing this important work together, and have a wonderful day. And if I see folks,
Thank you.
the words, the deeds.
Thanks, everyone.
Thank you. Bye.